Hello everyone, this is Dr. J and welcome back to the channel. I have a 4-case compilation for you today. We've got some dry flaky skin, we've got some ear fungus, we've got an ear tube placement, and then just a classic old earwax removal. This first case is an older gentleman that had hearing loss, fullness pressure in the ears. And when we looked in the ear, we could see immediately that he was completely obstructed. I could not see the eardrum. So we set him up, laid him back, brought in the microscope, and started to work on him. His wife was watching in the background, and she was pretty amazed what was happening up on the monitor. They'd never seen the inside of an ear before like that. So you see here we're using the right angle just to lift up the old skin combined with earwax. It creates a keratinaceous debris. It's just super dry. And so the treatment regimen for someone like this, number one, would be to remove the obstruction, which is what we're doing now. And the second part would be to get them on a regimen to prevent this from happening again. And you can kind of see here the patient is jerking a little bit under the microscope because as we're starting to pull the skin or keratinaceous debris off of the ear canal, it's exciting the Arnold's nerve or the ear cough reflex. And so I'm trying to be as gentle as I can as I'm peeling that off. And sometimes the skin that's peeling off as it comes off, it can be a little tender. It can be just a little bit uncomfortable for patients too. So you don't want to just grab and yank. You want to be gentle as you're pulling the old skin off of the ear canal. Pretty big skin plugs there. Now we're just going to go back in, start tidying things up, getting all the smaller fragments out, but they're all pretty stuck. And so this is why I'm not using the suction at this time. It's going to come out much easier if you just grab it and gently pull these fragments out. The alligator, what I'm using here, is probably the best instrument we have for actually grasping stuff that's in the ear canal. Here we actually switch to, you can see here there's just a little bit of moisture that is making it just a little bit softer. And in that scenario, it gets a little harder for the alligator to actually grip onto it because it slips off. So I used the suction there to start pulling it up, and then once we had enough to actually grab onto, then we can finish it off with the alligator again. And that last little fragment's out. Now we got some stuff out front here. This is where it's the driest and hardest, and it's really stuck to the skin, and sometimes you have to apologize to the patient because that's where the hairy part of the ear canal is, right at the opening, and sometimes you do pull some ear hairs in that process. And this part here, he tolerated very well. It looks like I'm being aggressive here, but it's just old dead skin that's sloughing off here. So the reasons why I haven't posted as many videos lately, it's the same things I've said before. I'm a busy practitioner. I'm actually in the operating room these days, probably 3 days out of the week, and I'm in the clinic 2 days out of the week. And then I'm on call on the weekends half the month. So it's just a busy lifestyle. Got a full family too, so apologize. As we approach the deeper part of the canal next to the eardrum, as I start to peel, he's too reactive, it's too sensitive, so I go ahead and stop it there and just lay it back down. Case number 2, otomycosis. The other term, or what is otomycosis? That's Latin for fungal otitis externa, or a fungal ear canal infection. And it goes from the outer part of the ear canal all the way to the eardrum. This does not involve the space behind the eardrum. As you see here, fungal spores. You can get brown, kind of dark, blackish spores, and then you can have white, cottony type of spores. And this is usually Candida species. You could get a culture, but the treatment would be the same. And that is, number one, debridement. You have to clean as much of the fungal elements out of the ear canal as you possibly can. And then you may have to do that frequently. So people who have a very aggressive otitis externa that is fungal, you have to bring them back frequently for debridements. Sometimes they'll require multiple debridements in addition to topical medications. My go-to medication for a topical fungal infection is a drug we have here in America. We call it cortisporin. It has antifungal, antibacterial, and a steroid combination. Oh, getting this out of the anterior sulcus there. That's really nice. And you use that for about 10 days. Tell them to keep the ear as dry as they can otherwise, and then you bring them back and make sure they're okay. I'm going to pause here for a moment and let you listen to this encounter.
I thought I'd ask you, but
So
don't do
we'll get you on some drops, a drop regimen. That'll probably be the best thing for your ear.
that. Oh,
And
okay.
all right, just gonna film me manipulating the skin and wax here.
Oh my gosh, is that all the wax?
Skin and wax, yep.
Oh my goodness. I knew I should have come in earlier. But I think, okay. Does it come in just for ear cleaning?
Yes.
That's the only.
No, you're not the only one.
Wow.
Now it's all clear.
Her biggest question was, can we come in frequently or have repetitive or recurrent scheduled visits for ear cleanings? And we do that. We do that very often for people, sometimes every 3 months, sometimes every 6 months, sometimes every 12 months. Everybody's just a little bit different on how frequently they come in. This is an ear tube case. We're putting in some topical phenol, which is a caustic chemical. And if you've ever taken like an organic chemistry class, you definitely have used phenol before. This essentially kills the skin and the nerve endings and the blood vessels in this region. So where it blanches out in this white area, that should be completely numb and bloodless. That makes it great for in-office procedure. And this is a myringotomy knife, and we're making just a little incision here in the back side or the posterior part of the tympanic membrane, and just wide enough where we can slip an ear tube in. And again, this was an awake patient in office. Only anesthetic was the phenol there. Everything else is fully sensate. And we use very gentle movements as a part of this, and we set the tube just in front, and then we use a smaller instrument to just tease the ear tube into the eardrum, and it should settle just nicely as long as you've made just the right size opening. And just tuck it in. The tube will be in place anywhere from 6 months to 18 months, and we'll have them back every 6 months just to monitor this and have them keep their ear dry. Thanks for watching. And we'll see you on the next video.